White spot lesions are common occurrences among many patients, especially children. White spot lesions start with the accumulation of plaque bacteria. The bacteria feast on sugars and release acids, which in turn attack the tooth enamel. The result is a shift in oral pH balance. This net loss of calcium and phosphate is called demineralization. MI Paste from GC America is a topical cream with recaldent CPP-ACP inside. When MI Paste is applied to the tooth surface, the CPP-ACP, a complex of casein phospholipid and amorphous calcium phosphate, delivers bioavailable calcium and phosphate to the enamel instantaneously. The calcium and phosphate are infused into the enamel, and the result is the strengthening and widening of the enamel rods, a process called remineralization. Remineralization is a result of a net gain in calcium and phosphate. For optimal oral health, apply MI Paste for 3 to 5 minutes twice a day. MI Paste from GC America, a breakthrough that has everyone smiling. Glass ionomer cements continue to increase in popularity, offering many important benefits for clinicians and patients. Let's look more closely at what happens when we mix and place a glass ionomer cement. During mixing, the glass ionomer liquid coats and reacts with the glass particles, releasing strontium and aluminum ions. These ions react with a polyacid to form a strong matrix which surrounds the glass particles. Water is an essential part of this reaction, and the final set cement contains approximately 20% water. Fluoride ions are also released during mixing. However, these form no part of the cement structure, and due to the remaining water in the glass ionomer cement, are mobile and free to move throughout the matrix. Prior to placement of the glass ionomer, it is helpful to prepare the cavity surface by applying a polyacrylic acid conditioner. After 10 seconds, the conditioner is washed off, removing the smear layer and surface debris. Excess water is then removed without over-drying the surface. Using a conditioner improves adhesion in 3 ways. It creates a clean bonding surface. It improves the chemical bonding potential of the glass ionomer cement, and it alters the surface energy of the tooth so that the cement can wet and adapt to the cavity more effectively. It is essential that the glass ionomer is placed while it has a glossy surface. The gloss is free polyacid, which is able to penetrate the cavity surfaces to form a strong, hydrolytically stable chemical bond to calcium ions within the dentin and enamel. In addition to chemical adhesion to calcium in the tooth, a fusion bonding process takes place as well. Calcium and phosphate ions from the polyacid-treated dentin and enamel, and strontium and fluoride ions from the unset glass ionomer intermix and precipitate, forming an interface called the interdiffusion zone. This zone is stronger and more acid-resistant than either the glass ionomer or the tooth. The combination of the interdiffusion zone and the chemical bonding provides the basis for a strong, stable adhesive interface and creates a bacteria-proof seal for the cavity, best described as a chemically fused seal. The initial penetration of strontium and fluoride ions into the tooth helps remineralize and harden any demineralized dentin, which is covered by glass ionomer cement. Essential to the success of this technique is strontium's ability to substitute calcium as an appetite-forming ion, and the ability of the glass ionomer cement to provide a bacteria-proof seal. Tooth surfaces surrounding or adjacent to the glass ionomer cement benefit from an initial burst of fluoride. This creates a peripheral zone containing increased levels of fluoroappetite. Glass ionomer cements, therefore, create zones of protection for surrounding tooth surfaces. Glass ionomer cements mature over time. However, their final strength is further enhanced by exposure to saliva after their initial setting reaction. Calcium and phosphate ions from saliva are able to penetrate into the set glass ionomer matrix, and this uptake further hardens the cement structure. Glass ionomer cements provide exceptional stability of the adhesive interface over time. Many external factors will challenge the integrity of bonded surfaces. For example, pulpal fluid, transmitted occlusal stresses, and thermal expansion-contraction stresses. Potentially most challenging to the integrity of a bonded interface is pulpal fluid. Fortunately, glass ionomer cements are unchallenged by fluid pressure from the pulp. In fact, pulpal fluid benefits the glass ionomer over time by strengthening the cement adjacent to the dentin surface. This is especially important now that we understand the negative impact positive fluid movement has on resin adhesives over time. The glass ionomer reaction is a complex one, and many benefits are obtained. A strong chemically fused seal, fluoride release, internal remineralization, and good long-term stability of the glass ionomer tooth interface. The many benefits offered by glass ionomer technologies have led to the development of low-viscosity cements, which are applied to tooth surfaces like a varnish, offering a long-term protective coating for surfaces at risk. Of special focus is the protection of exposed enamel surfaces on erupting first and second permanent molars. These teeth are at their highest risk of caries during the 12 to 24-month period of eruption. This procedure, often undertaken in situations where moisture control is difficult, is called fissure protection. In recent history, our understanding of the benefits glass ionomer cements offer has broadened. At the same time, GC Corporation has further developed the range and capabilities of cement technologies in the knowledge that glass ionomer cement remains the best adhesive interface option for the tooth.
Restoring the interproximal zone with composite resin restorations using conventional hybrid composites has always presented challenges. Improper placement of these viscous composite materials can result in gaps, voids, and deficient marginal seal at the restorative interface. However, by utilizing a modified self-etch technique and a simplified placement of a next-generation flowable, an ideal tooth restorative interface can be achieved. The patient presents with interproximal caries on the mesial aspect of the mandibular left lateral incisor. After radiographic evaluation, a shade comparison and determination was performed prior to the restorative procedure. The dehydration of the tooth from water molecules being depleted from the enamel rods can result in improper shade matching. Once anesthesia had been administered to the patient, the caries was removed with a number 2 high-speed round burr, which produces rounded line angles. The outline form was as conservative as possible, without removing healthy tooth structure, unless dictated by caries. A circumferential bevel is placed in enamel using a tapered diamond burr, a DET3 by Brasseler USA. An enamel bevel is indicated because it increases the surface area for end-on etching of the enamel rods for an increased etch surface, which results in a stronger enamel to resin bond, which increases the retention of the restoration and reduces marginal leakage and discoloration. The preparation was cleaned with a 2% chlorhexidine solution, Conceptus by Ultradent, rinsed and lightly air-dried. A dead metal matrix was placed and secured in the interproximal zone, and a selective enamel etch procedure was performed. The prepared and the unprepared enamel was etched with a 37.5% phosphoric acid gel etchant by Kerr, for 15 seconds and rinsed for 5 seconds. A self-etch adhesive Geniobond by GC America was placed on the enamel and dentin surfaces with an applicator tip for 10 seconds. Air dried for 5 seconds using an ADEC warm air tooth dryer, and light cured for 10 seconds. The dead metal matrix was replaced with a mylar plastic strip in the interproximal zone to confine and adapt the composite material to the tooth surface. The mylar strip produces a smooth surface while maintaining the anatomical contour during the polymerization process. A bleach-shaded flowable composite material, Genial Universal Flow by GC America, was injected into the preparation, and the syringe tip was slowly removed while extruding the material, and the mylar strip was firmly adapted to an ideal contour and light cured for 40 seconds using a ramp mode. The material is thixotrophic. This property allows the material to structurally break down so it flows through the syringe tip when the material is stressed, and then it restructures and becomes more viscous. Uno and Asmussen suggest that using a slower polymerization causes an improved flow of molecules in the material while decreasing the polymerization shrinkage stress in the restoration. The mylar strip was removed and the interproximal region was inspected for any residual composite resin tags or overhangs. The excess residual resin was removed with a surgical blade, a number 12 BD Bard Parker by BD Medical. The proximal surface were cleaned and smoothed with a loose abrasive diamond polishing paste, which was carried into the interproximal region with finishing strips using the ET composite polishing system by Brasseler USA. The proximal surface was inspected for adequate contact with an unwaxed floss prior to removing the dental dam. After the dental dam was removed, a definitive luster and surface reflectivity was accomplished with a goat-haired wheel and diamond polishing paste using an intermittent staccato motion. The following restorative procedure demonstrates the optimal aesthetic results that can be achieved in the interproximal zone through proper adhesive protocol and a simplified application of flowable composite resin. And also notice the radiopacity of Genial Universal Flow is similar to enamel, which makes it easy to evaluate the interface and to identify recurrent caries. Today, improvements in resin chemistry technology, optimization of material properties, and the development of innovative techniques for placement have made composite resin more user-friendly and reliable. Until recently, the flowables were clinically indicated and acceptable as filling materials in low-stress applications such as cavity liners, sealants, preventative resin restorations, small class 1 restorations, class 2 substructure, small class 3 restorations, and class 5 restorations. And what other material has so many uses than these next generation flowables? The following presentation will describe a few of those many contemporary applications utilizing Genial Universal Flow. For anterior and posterior composite restorations, by utilizing precise restorative placement techniques and conservative adhesive preparation designs and a more thorough adhesive protocol, these advanced formulations such as Genial Universal Flow can be utilized for Class 1, Class 2, Class 3, Class 4, and Class 5 restorations, diastemic closures, and direct veneers. Studies indicate that incremental layering techniques with these materials can be effective in reducing the effect of contraction stress and improving marginal sealing, and these materials can be used independently or in combination with conventional hybrid composite materials. For composite mock-ups, the composite mock-up is an excellent tool for increasing the patient's understanding and education of the clinical procedure through a visual prototype. This composite prototype allows the patient and the restorative team to establish parameters for lip profile, incisal edge position and length, and orientation to the gingiva, and to simulate the final result. This process can be performed intraorally, without anesthesia and can provide valuable information for proper lip position and phonetic considerations. A clear vinyl polysiloxane impression can be used to replicate the diagnostic wax-up. The matrix can be placed intraorally and used as a transfer vehicle for the flowable composite to be injected. As sealant and preventative resin restorations. Next generation flowables can be utilized as composite surface sealants, pit and fissure sealants, and preventative resin restorations. These highly filled nanomaterial formulations can be cured in a thin film and have the potential to increase the wear resistance of posterior composite resin restorations. Since the interparticle spacing is reduced and the filler particle density is increased, and thus can provide more reinforcement and protection of the resin matrix. These materials can be utilized to fabricate, modify, or repair provisionals. Composite provisionals can be efficiently fabricated by making an initial impression with a clear vinyl polysiloxane impression material, such as Memicil 2, of the preoperative stone or diagnostic wax-up model. Also, long-term provisionals can be utilized for the shaping and development of gingival contour for edentulous regions and for the manipulation and shaping of interproximal papillae during prosthetic implant therapy. For composite tooth splinting. Composite tooth splinting has widespread use in dentistry for stabilization and immobilization of teeth, for orthodontics, periodontics, oral surgery, pedodontics, and general dentistry. It provides tooth fixation through application of a light-cured flowable or chemically cured composite material to acid-etched enamel surfaces in combination with flexible stainless steel wire, orthodontic brackets, or fiber-reinforced ribbon. To enhance internal adaptation, these next-generation flowable composites, such as Genial Universal Flow, are 69% by weight, with an average particle size of 200 nanometers. The low modulus composite acts as an elastic buffer that compensates polymerization shrinkage stress by flow, eliminating mastication discomfort and theoretically eliminating cuspal deformation or gap formations and reduced microleakage. Also, the flowable materials may enhance the wetting capacity of the restoration, resulting in a more complete interfacial internal adaptation, reducing void formations, which can contribute to a weakened surface and microleakage. These next-generation materials can also be used for transitional intraoral repair of fractured ceramic restorations. Application of flowable composite resins for the intraoral repair of ceramic restorations can increase the longevity and improve the aesthetics of fractured restorations and offer the patient and dentist a cost-effective alternative to replacement. Flowables can be used to stabilize, secure, and seal the dental dam clamp prior to procedure. Endodontic and adhesive procedures require proper isolation, and these flowable materials can be used to stabilize, secure, and seal the working field. Creating a vertical stop for interocclusal records. Flowable composite resin can be used as an accurate interocclusal record for the orientation of models for fixed prosthetic restoration. To resurface or repair composite restorations. Repeated flexural forces can also cause adhesive failure of adhesive restorations at the dentin resin interface, which can result in microleakage and partial or complete debonding of the restoration. A simple indirect direct technique can be used to restore anatomical morphology from wear or fracture using these next generation flowable materials. Sealing endodontic access openings. An inadequate coronal seal after endodontic therapy can allow slava to reach the apical region of the tooth in as little time as 3 days. One material and method that can be utilized for sealing the endodontic access opening is a simple technique that involves self-etch adhesives such as Genial Bond and a next-generation Flowable. This bioadhesive procedure can restore or provide a transitional seal until a new restoration can be placed. Repairing denture teeth. Generally, fractures to denture teeth occur as emergency situations and require replacement. Replacement can be achieved with relative ease in the laboratory with an adequate inventory of denture teeth. However, with a proper surface treatment, these fractures can be repaired with next-generation flowable composite resins such as Genial Universal Flow at chairside. Eliminating cervical tooth sensitivity. One effective treatment strategy for eliminating cervical tooth sensitivity is to occlude the distal terminal ends of the exposed dentinal tubules. Adhesive resin impregnation is a clinical technique that has increased in popularity in recent years and is currently considered one of the most definitive and rapidly acting methods of desensitization. This procedure reduces sensitivity with application of a dentin adhesive and flowable composite to form a hybrid layer, and this resin barrier prevents continued diffusion of toxins and bacterial invasion toward the pulp while producing minimal adverse pulpal inflammation. Although this biomaterial, Genial Universal Flow, has so many potential uses, the selection of the proper material for any particular clinical situation requires many consideration factors, including the biologic, physical, and mechanical properties of the material, the placement technique, cavity configuration, anticipated margin placement, curing light intensity, tooth anatomy and position, occlusion, patient's oral habits, and ability to isolate the operative field. All of these factors have the potential to influence the clinical behavior and material performance, and each should be considered prior to restorative treatment. In view of all of these considerations, it is understandable that clinicians have uncertainties about selection of biomaterials and techniques to optimize the material's properties and to achieve predictable long-term results. To improve this selection process, the restorative dentist must have a working knowledge of these consideration factors and integrate this knowledge with the proper technique for each clinical situation.